Good afternoon, and thank you so much for joining us today. My name is Sharon Bogan from Public Health Seattle and King County, and we're glad that you are all here to join us today to hear more about the impact of COVID-19 in long-term care facilities. I'll go through some logistics, but first, just to introduce a little bit more information about our speakers today. Today we have Ingrid Ulrey with us. She is the Policy Director for Public Health Seattle and King County, and she is also lead for Public Health Long-Term Care Facility Response. In addition, we have Dr. James Lewis, and he is the clinical lead on healthcare system support for Public Health Seattle and King County. So before we begin, a few instructions for media as far as being able to send your questions. You're welcome to send questions using the chat function. You'll need to select moderator to send your questions. So feel free to do that during the telebriefing, and then we will select questions. We may not get through all of them, but we'll do the best we can, and we'll select questions, and I'll read the questions then to our speakers once we get to the Q&A section. When you do put your question in the chat box, please include your organization so we know your organization you're with, as well as your name. So we're here today, as I said, to talk and learn a little bit more about the impact that COVID-19 is having on long-term care facilities. It's been a large impact in our region as well as nationally, and also to talk about the public health response to the issues. So first, we'll hear from Ingrid Ulrey, and Ingrid's name for spelling is I-N-G-R-I-D, last name Ulrey, U-L-R-E-Y. Once again, our policy director here at Public Seattle and King County. So with that, Ingrid, I will turn it over to you for some initial remarks.
Sharon, thank you so much, and thanks everyone for being on the call. Nationally and locally, the older adults and people with disabilities living in nursing homes and other long-term care settings have been really hard hit by this pandemic. Across the U.S., it's estimated that more than 25,000 people have passed who are associated with long-term care facilities. And the sudden loss of life care in Kirkland that started in late February was really an alarm call for everyone across the nation, definitely for us locally. Since that time, despite really the best effort of the people who run these facilities and work in them to keep people safe, as of today, 327 people associated with long-term care facilities in King County have died. And these deaths represent more than 60% of all the COVID-related deaths in our county. The reason for this is that these facilities really create perfect storm for a coronavirus outbreak. They include clusters of older people, people in their 80s and 90s and beyond, who have significant underlying health conditions, who live in close proximity to one another, and who are also heavily exposed to the many staff who provide their care. The outbreaks that we're seeing in these facilities are occurring both in nursing homes and in community. The majority now of King County's 52 nursing homes have been affected, which means they've had at least one confirmed COVID positive case. And unlike younger people in the community who test positive, perhaps experience a brief illness and then get better, a very, very high percentage of older people who live in nursing homes become severely ill. In addition to life care, we have 5 other nursing homes in King County who've lost more than 15 residents to COVID-19. Our county's 148 assisted living facilities have also been deeply impacted, with more than 1 in 4 having 1 case or more. Many of these assisted living have memory care units, housing people with dementia, who may not have the capacity to understand why have conditions changed and may be unable to follow social distancing protocols. Finally, I want to mention the outbreak in the Numis adult family homes. These are small neighborhood homes licensed to care for up to 6 residents. We have 1,000 adult family homes in county, 50% of which are in South King County. We've had so far 28 deaths reported in adult family homes. Some of these homes have become so impacted with positive residents and positive staff that they've had to close their doors and transfer remaining residents. Across all three facility types, residents, their loved ones, and the staff are all highly impacted. Most of the cases and pretty much 98% of the deaths have been among residents. To mitigate the spread of the virus, the resident's ability to move freely around the facility or to receive visitors has been strictly curtailed. So sadly, this means that most are confined to their rooms and probably really suffering from social isolation. Families and friends of these loved ones are worried but unable to communicate other than by phone or FaceTime or wave through the window. Thousands of nurses, certified nurse aides, and other staff are working really hard to care for these residents, even though they're putting themselves at risk, especially if they don't have access to appropriate PPE. Our data show that this workforce is overwhelmingly middle-aged women, a high percentage of whom are women of color. Many have tested positive for COVID, and as they become sick or unable to work or just afraid to go to work, it exacerbates the short staffing problem in these facilities, which has already been a challenge even before this pandemic. The good news is there's a lot we can do to beat back the virus and protect people in long-term care facilities. Really strong infection control can keep the virus from entering a facility and mitigate the spread once it does. And testing is critical to identify who's COVID-positive and act on that by asking workers who are positive to stay home and by separating the sick residents from the well as best we can within a facility. I'm going to turn this over in a minute to Dr. James Lewis to talk through more detail with you on our public health response. But before I do, I want to emphasize that containing the virus within the long-term care facilities is important not only for people who live and work in those facilities, but really for all of us, for the broader community. Admissions from these facilities to hospitals when people get sick runs the risk of putting our hospital system over capacity. While we are fine now on this front in terms of hospital capacity, changes in new outbreaks in long-term care facilities, or a second wave could really make this worse. Containing the virus so that everyone can go back to work and school and return to our normal lives really is not going to be possible unless we put out the fires still burning in these facilities. So Sharon, I'll turn it back to you now for more from my colleague.
For your insights and perspectives. Now I'd like to turn it over to Dr. James Lewis, and that is spelled James, J-A-M-E-S, last name Lewis, L-E-W-I-S. Dr. Lewis is the clinical lead on healthcare system support. James, I'll turn it over to you.
Thanks, Sharon, and thanks, Ingrid. That was a very good summary of the terrible situation that the long-term care community finds themselves in now. And public health is working very hard to try and help mitigate this problem. And we really have a three-pronged approach that Ingrid already mentioned briefly, which first includes general infection prevention guidance. And when you hear that, you might think of just hand washing, but it's a lot more than that. I mean, certainly there's almost always room for improvement in hand washing, but the other big things are this pandemic has introduced new PPE that maybe the long-term care facilities haven't been used to using on a regular basis in the past, and that includes eye protection, face shields, and N95 masks. And then also some special considerations around cohorting and specific medications that people would normally use without any concern, or equipment that people would use without any concern, such as nebulizer treatments and BiPAP or CPAP devices. And so we are able to provide general infection prevention guidance around the use of all of these, as well as just your normal infection prevention that most of these facilities are very good at already. The next step is testing, and so we are trying to facilitate testing in a lot of these facilities. And ideally, we would love to have tested everybody in all of the long-term care facilities across the county even weeks ago. But we have had some barriers around this, which I'll talk about shortly, that have made this not possible. The final step is, what do you do with those testing results? And that was what Ingrid was referring to when she spoke about separating the sick from the well. So this is commonly in our business referred to as cohorting. And so that's moving the people who have COVID to different parts of the building so they're less likely to expose those who don't have COVID, or at least who have tested negative at that point in time. And also removing staff that test positive and keeping them home until it's safe for them to return to work. I mentioned the barriers that we've had to implementing this, and that's primarily around testing, and it's mostly shortages of test kits as well as PPE. So this is mostly the swabs and the viral transport media that you need to perform these tests. And so we've really been limited in our access to those, and so had to prioritize our interventions because of that. And then also the PPE that we need to perform the tests, and also for the long-term care facilities to take appropriate care of their residents once positive cases have been identified. So we're working hard to improve those issues, and it does seem that things are getting better on that front, but there's still some work to do there. There's also some concerns about future challenges. So as most of you probably already know, the testing really provides you a snapshot in time. And so further testing is going to be required in the future. And so public health is not going to be able to support all of the testing that needs to go on over the next however long the pandemic lasts, likely at least several months, if not longer. And so large numbers of uninsured staff in this sector, as well as lack of having physician oversight of many of these facilities, like in the adult family homes and the assisted living facilities, make it difficult to have an ordering provider for a lot of these residents and staff. Despite these barriers, we've made a lot of progress. We've tested over 40 of the skilled nursing facilities in King County to date, and we have learned a lot from that in the last several months, or in the last few months. So testing has revealed the highest risk of transmission is in our skilled nursing facilities, as opposed to our adult family homes and our assisted living facilities. That's where we're seeing the highest proportion of cases. And then we're trying to systematically perform testing of all residents and staff in all the skilled nursing facilities. I mentioned we've already done that in over 40 of them. We work with multiple partners to make this happen. So it's not just public health. We can't do it alone. So we're working with the Seattle Fire Department, as well as multiple healthcare system partners, including University of Washington, MultiCare, Kaiser Permanente, Evergreen, Overlake, Providence, and CHI Franciscan, among others. So along with this, we're not just doing the testing. As I mentioned, we have to do testing moving forward as well. And so we're attempting to help build the infrastructure to make testing possible moving forward without the direct assistance from public health. And so the infrastructure that needs to happen is having access to test orders, having access to testing kits, and having staff or contractors that are able to do the testing for those facilities. We also are not just focusing on this kind of proactive approach of doing testing in the facilities, systematically in all the skilled nursing facilities. We also are reacting to outbreaks that are identified or cases that are identified in individual facilities. And for each of those facilities, we assign an investigator here at Public Health who is following up with them on a regular basis, at least a couple of times a week, and then always available for questions that come in from the facilities, and they have direct contact information for that investigator, and they stay in contact until that facility has not had any new cases for a 14-day period. And then we also provide testing support, at least for symptomatic individuals. We would love to do more in those facilities as far as testing is concerned, but as I mentioned, we've had limitations in our testing kit supplies. And this work is having an impact. So while our deaths on a weekly basis in long-term care have stayed steady for quite a while now, around 60% of the deaths that are reported are still in long-term care facilities, the number of new cases that are being reported on a weekly basis have dropped significantly. So in March, it was around 20% of all new cases identified were in long-term care residents or staff, and now we're down to around 8%, or 7%, excuse me. So we are having an impact. But we're going to have to be very careful moving forward as soon as transmission starts coming back up in the community, we run high risk of transmission getting back into the long-term care facilities. So we need to be very careful, but it is hopeful that we are having an impact on the incidence of cases in these facilities. Thank you very much. I'll turn it back to you, Sharon.
Thank you very much, Dr. Lewis. So now we'll open it up for questions and answers. As a reminder, you'll want to select moderator and send your question in the chat function to the moderator, and we'll ask some questions. I'll give a few moments for media to ask their questions. And while those questions are coming in, Ingrid, can you speak a little bit about the partnerships that have been built both with state partners, health system partners, to be able to do this work, particularly around some of the expansion of testing and work in long-term care facilities?
Sure, Sharon. Yes. So there are key partners at state level. The three types of facilities that we're speaking about, skilled nursing facilities, assisted living, and adult family homes, are all licensed by the State Department of Social and Health Services. So we have been in close coordination. The role of that department, called DSHS, is to regulate and license these facilities. So we've been collaborating with them on a daily basis about what's happening, what we're seeing, and they are supporting us as well on infection control support and recommendation to the facilities. The DSHS plays a key role, as well as our State Department of Health partners are working with us on this project. And locally, we've seen a tremendous and helpful response from health systems. Health systems have subacute coalitions where they release people from hospital to these skilled nursing facilities, as well as the other types, and care deeply about the health of the residents in those facilities, and have been willing to take on some assistance role with us in helping to test a number of these facilities, directly helping out, going out, working with the administrators of the facilities to do the testing. We greatly appreciate that. That includes UW-Washington, University of Washington, as well as others. And in our fire department here in Seattle, Seattle Fire has also assisted with testing, not only in the skilled nursing facilities, but also most recently in adult family homes, as well as assisted living. So it takes a village. I also want to call out the assistant, the Adult Family Home Association, as well as the State Long-Term Care Ombudsman, who are supporting us with a pilot of adult family homes in South King County. So it truly has taken many, many partners working in concert together to get this done.
Thank you so much. We have a few questions coming in from media. The first one from Cairo. Wanted to know, what are some of the worst hit facilities other than life care? And one thing to note, and I know Dr. Lewis, you can respond more about this, but we have launched more data accessible on our website, including dashboard, and that includes lists of long-term care facilities where we've had cases, and particularly those that have had cases, more than 5 cases. But Dr. Lewis, I'll turn it over to you to address where are some of the worst hit facilities.
Yeah, thanks, Sharon. So yes, this information is on our dashboard, and we have listed all the facilities with 5 or more deaths associated with them. So among these are Enumclaw Health and Rehab, Richmond Beach Rehab, Issaquah Nursing and Rehab, Redmond Care and Rehab, Park Ridge Care Center. Those are all over 15 deaths associated with their facility. None of the facilities have had as high of an impact as Life Care did, and I think that has a lot to do with the community reacted very strongly to the situation at Life Care and really did a lot to try and mitigate the COVID from getting into the facilities after that.
Thank you. Here's a question from Q13, and Ingrid, I think this will be one for you to start with. So the question is about early on in the outbreak. Was there state planning at the state level to prevent or limit COVID-19 in long-term care facilities, and was that implemented away? What is your insights into planning at the state level?
Thanks, Sharon. Yeah, so early on, it became clear very early in the outbreak that a major high-risk population were going to be the people living in long-term care facilities. Very quickly on the governor and his office, as well as the DSHS I mentioned previously, as well as our State Department and others, came together to think about how to respond. A key element of the response is the PPE, the personal protective equipment. So we worked extensively with state partners in coordinating the distribution of the PPE to long-term care facilities. There is a prioritization list because of the unprecedented shortage of PPE nationwide. It's been a priority. Long-term care facilities are now, even those with or without a case, are in Tier 1 for distributing the PPE that flows from the federal government to the state government and here to our King County Office of Emergency Management. So we really worked hand in glove with the state on doing our very best to distribute PPE to long-term care facilities. That's an example. Also in testing, the test kits, coordination around availability of test kits. It's been very much through our State Department of Health. We've provided them with information about how many kits we need to get into the long-term care facilities to do the testing, and they've been very responsive. And just today in the news is information that the governor is likely to announce a recommendation of testing all residents and workers in nursing homes. So for example, just this morning, James and I and our staff here at Public Health were on a call talking about what our experience has been in King County, how close are we to that goal, and how can we support our jurisdictions across the state to test everyone in this sector.
Thanks, Ingrid. We have a question from KUOW, specifically about, and this is for you, Dr. Lewis, the number of facilities that have had one or more COVID cases. And again, our dashboard will continue to update this information, but also proportion of all care facilities in King County have had a case. And if you don't have the numbers right at your fingertips, we can also follow up.
No, I have that from, we have a printout of the dashboard here, so I would definitely refer back to the dashboard, but we break it down by the type of facility, since the three different types of licensed long-term care facilities have very different characteristics. And so out of our 52 skilled nursing facilities in King County, 36 of them at this point have had at least one case, so that's 69%. And then out of the 148 assisted living facilities in King County, 41 of them have had at least one case, and that's almost 28%. And then of the approximately 1,000 adult family homes in King County, 28 have had a case, and that's 2.5%. And I would just like to point out, with regard to the assisted living versus the adult family homes, while there's a larger proportion that have had a case, if you think about it in terms of cases per, say, 100 people, there are approximately twice as many residents in assisted living as there is in adult family homes. And so the attack rate or the number of cases in adult family homes is approximately equivalent to that of the assisted living facilities, if you think about it in terms of cases per 100 population.
Great, thank you. I have a question from Patrick from Como. So the governor's office has told us that they've directed all nursing homes statewide to undergo testing in the next few weeks. And this is in accordance with recommendations from President Trump. So Patrick was wondering, are you aware of the directive, and what's your plan to accomplish this? And let's start with you, Ingrid, on this.
Yes, we're aware of the directive. We were on the phone this morning speaking with our partners at the state government about this. We agree with the directive, and we feel like we're a little ahead of the curve because we were already on track to test all residents and workers in nursing homes or skilled nursing facilities. So as James said, we've completed that sort of full testing in 44 out of 52 of the nursing homes in King County. That would not have been possible without great collaboration with the facilities themselves, as well as our health system partners. So we're not surprised to see the directive. It has been a recommendation previously from the CDC, and it makes sense because these are such high-risk facilities. If we're testing only symptomatic individuals, the problem is that we have people who are COVID positive who are asymptomatic, so would unknowingly spread the virus. And it's really critical to test the worker as well, because even if you're able to contain the virus within a facility, if you have people coming in and out who are caring for the residents who continue bringing the virus back in, we'll never contain this. So the directive from the governor makes sense. It's not an easy task. It's actually a monumental task with many challenges and barriers involved, but we've made good progress towards it in King County. Depending on what comes out with the governor's directive, people are going to need the time and the supplies necessary to get this done.
Thank you. And speaking of supplies, and I know you both touched on this briefly, but Dr. Lewis, there's a question also about testing capacity to be able to test all nursing homes. And you allude to both testing capacity, but also PPE. Anything you want to add about the capacity and ability to do this testing in an ongoing way?
Yeah, so, I think Ingrid did a nice job talking about the situation and what we need to make it happen. And we're in active discussions about how it's going to get accomplished. Luckily, as Ingrid pointed out, we are very close to having that accomplished here in King County already, which is great. But that is, as I kind of mentioned earlier, the testing with the PCR test, that's the primary diagnostic test for the coronavirus, is only gives you a snapshot in time. And so for it to be as useful as it possibly can be, I do think there's utility in one-time testing as far as helping mitigate the spread in facilities. But for it to be as useful as it can be, you really need to do ongoing testing on some regular basis, whether that be some period of days, a week or 2 weeks, but really going beyond 2 weeks, it becomes less useful. So you really need to be able to do testing on a frequent basis. And so in order for that to be realistic, we're going to have much better access to test kits and PPE. And that is improving, but I think we have a long way to go to get to a point where we can do that kind of testing anywhere in the country, not just here in King County.
Great, thank you. This is a question from Q13, and I think Dr. Lewis, you can weigh in from a clinical perspective, Ingrid more from the policy perspective. The question is about some lawmakers who are calling for patients who are hospitalized to have a negative test result before being admitted to a long-term care facility. And so the question is about where you all support this for King County, and any thoughts on?
I can jump in on that one. So, I think that we're actually working on guidance around this. I think it's under review at the Department of Health right now. We would support having a test before getting discharged to a long-term care facility. We would not support it necessarily being negative. We wouldn't want a facility that was unable to appropriately care for a positive patient to take them. But we really do need the long-term care facilities to be able to take patients out of the hospital, as it's really, we have plenty of capacity in our hospitals right now, as Ingrid mentioned. But if we do end up having a second wave of cases here in the coming months, then we really need the ability to free up the hospital beds and get the people to the appropriate level of care so that people who need hospital level care can have it. And so while we definitely support doing a test before someone gets discharged so they can be cared for appropriately, having a negative test is not something we would support. Now, an individual facility, if they can't take care of a positive patient, that's a different issue.
Anything you wanted to add to that, Ingrid?
Well, there's a recognition, I think, now at the state level that we need safe isolation facilities for people who are COVID positive, who have a nursing home eligible level of care need. So there is a new program set up called the COVID Transfer Program, wherein the state is contracting with skilled nursing facilities to receive an enhanced rate and in exchange for admitting individuals who are COVID positive and having the resources to care for them. So that's important, both what James said of ensuring that we have a relief valve to get people out of the hospital as they're recovering from COVID. It's also important in the case of, for example, an adult family home, if they are so impacted with sick residents and workers and they need to transfer to a safe place to isolate, having skilled nursing facilities who will accept good positive individuals is critical. So we have that established. There's one live contract that's happening now that skilled nursing home will admit COVID positives, but we're going to probably need more capacity than that.
And I think this question from Cairo follows up a little bit more on what you were just talking about, Ingrid. So Cairo is asking that in the context that there may be a second wave, do you feel long-term care facilities are ready, and how close are we to being ready and having a sustainable testing plan in place? So you began to talk a little bit more about that, but anything you wanted to add?
to be ready, they're really going to have to, in the most aggressive way possible, implement infection control measures. So already we're coaching. Our staff here at Public Health are fantastic about coaching in person and by phone. All the specific measures people can take, from not just from hand washing, but donning and doffing PPE properly so you don't cross-contamination, and little things like people not using the same pen to fill out forms or not touching the same screen to push buttons. So really spending more time supporting our long-term care facilities on proper infection control and prevention is key. The other is what we've talked about already a lot in this call, is that capacity for ongoing, not just a one-time point prevalence point-in-time test, but ongoing retesting so that people can properly identify who's positive, even if those individuals are asymptomatic. So that sustainability of ongoing testing, which is going to require PPE testing, and in the facility in assisted living and adult family homes will require an ordering physician to order those tests, which is a key piece of the puzzle that's missing right now.
And I would just add on to what Ingrid said, that I think, ready and not ready, it's not a black and white. Readiness is a continuum. And so we're definitely in a much better position now than we were back at the end of February or early March. And I think that really, supports the data that we're seeing with the decreasing incidence as compared to the total number of reported cases. The percentage of cases coming from long-term care facilities is steadily going down. And that, I think, is a result of improved infection prevention and control measures, and then also, and just readiness in general. And then also the number of the fact that no facility has gotten into the same boat as Life Care did, I think is also testament to the fact that our long-term care facilities are much more able and ready to take care of these patients than they were before. Is there a lot of work still to be done? Yes, absolutely. But we're in a much better place than we were at the beginning of the year.
Thank you both for that. This is a question from KUOW. The question is about residents of care homes are discharged from hospital settings following a COVID illness, and they're recovering at designated places such as Richmond Beach. And you talked a little bit about this, Dr. Lewis, but talk a little bit more about this approach and why it's so necessary.
Yeah, so this is referring to having dedicated COVID positive facilities, or at least units within specific facilities that are COVID positive. And so this is really critical for us to be able to take care of patients for a number of reasons. One is just logistical, a logistical reason of hospitals being able to free up their beds so that they can take care of either other COVID patients that need the space or patients who need regular routine medical care for normal urgent issues that require hospitalization. So that's one big part of it. But then the other big part of it is having facilities that have dedicated COVID areas and have people that are dedicated to taking care of the residents in those areas that, have more experience perhaps, or are at least dedicated to those residents, and they're not providing care to other residents, really limits the spread and incidence of new cases in those facilities. So that's why this is very critical.
Great. And this is a follow-up question from Como. And the question is about the testing in the rest of the long-term care facilities. So is there hope or plan to test residents and staff there? And I think this is in reference to how many facilities we've been able to test thus far and what the plan is moving forward. So Ingrid, do you want to start, and then Dr. Lewis can add in?
Sure. Thank you for the question, important question. Here's the plan. So first and foremost, first priority was skilled nurse facilities. Second priority is adult family homes, where we see individuals with a very similar level of risk, also exposed to other individuals who they may share a bedroom or bathroom with, and we're seeing some level of outbreaks. So our goal with the adult family homes is to do a pilot, which we've already started, to test 60 adult family homes out of the 1,000 initially, and then take a look at our results and see what the trends are. We're able to do that with the partnership of the Seattle Fire Department, who will be testing a portion of those, about 20 in Seattle, and with the partners of the Long Care Ombudsman and the Adult Family Home Association, who are helping us to identify 40 homes in South King County. And we're focusing in particular on homes who take a high percentage of Medicaid residents. So that's the approach in the adult family home. it is much harder, both in adult family home and assisted living, because these types of facilities don't have the medical oversight and infrastructure that we see in a skilled nursing home. So they don't have a medical director to order the test. So this has been a challenge. They also have a number of staff who are unsure. So those two barriers are something we're struggling and grappling with, but we're committed to going out and doing the pilot in adult family homes to see what we find. And in assisted living, the priority within that sector are those with memory care units. We are very concerned about people with dementia or cognitive decline who are unable or don't understand the need to follow social distancing protocols, the increased enhanced risk in assisted living. But assisted living, we have the same problem of no ordering physician. On a high note, in assisted living, we feel that individuals are typically in assisted living in their own apartment, not having to share a bedroom or bathroom with their resident. So in some ways that reduces their risk, but we are concerned about both of those sectors and look forward to working more with our partners as well as state government to remove some of the barriers to testing in those sectors.
Yeah, and I would just add on, that was a great summary, and just a couple more points about how we prioritize. So certainly based on the risk of transmission, which Ingrid got at, with assisted living facilities having their own apartments, their own kitchens and bathrooms much of the time, certainly their own apartments, really limits transmission. But in addition, we prioritize based on where the highest risk populations were, so the people who would be at highest risk for having severe disease if they do get infected, and that's certainly the skilled nursing facilities. And then also, what can they do whenever they identify positive cases? So it's much more difficult to do effective cohorting that I mentioned earlier, so separating sick people from well people in assisted living facilities where people have their own apartments much of the time with a lot of their own stuff, including furniture. And so it's a lot harder to do those interventions in an assisted living facility as opposed to a skilled nursing facility where often there's roommates and less personal belongings in the rooms. And then somewhere in between is the adult family homes. And so that's why we listed those there. But certainly memory care units within assisted living is a special priority within that assisted living population.
Great, and this will be the final question. It's two parts here from Q13. Does the county know what number of tests are needed to regularly test at long-term care facilities? And does regular testing include staff?
Yeah, so that was actually brought up on the meeting this morning. So according to survey results that DSHS received from the long-term care facilities, in order to do testing just in the skilled nursing facilities, there would need to be about 37,000 tests to complete that. And so if you're doing regular routine testing, so that would include, let's say, just to be conservative, let's say weekly testing for all of those, that would be 37,000 tests a week just for the point prevalence surveys or testing everybody in a facility. And then on top of that, you're going to need to do some reactive testing. And so there would need to be more than that. And that's just for skilled nursing facilities. So you can imagine probably at least twice that many on a weekly basis to do testing in all long-term care facilities. And yes, it does. Testing does include staff.
And just to follow up, Dr. Lewis, is the 37,000 number, is that for King County or statewide?
That was statewide.
That was statewide. Okay, thanks for the clarification. Ingrid, anything you wanted to add or some final words before we wrap up?
I would just say Washington is a unique leader in the country for the ability, the extent to which we've been creative at giving people options to stay in their own home or their own community when they need long-term services and support. So more so than in any other state, it's important for us to go beyond the nursing home population and attend to the needs of individuals with a similar level of vulnerability to COVID who live in the community-based settings like adult family homes and assisted living, as well as people receiving assistance from a home care worker. So that's essential. What we are seeing too, I would just note, is some family members are making the choice of bringing their loved one home, which they are receiving support from DSHS social workers in making that decision if they feel their family members are more safe at home. However, not everyone can do that. It's really not possible. Some of these residents have no friends or family to go home to. So it's really essential that we focus on this sector And again, not only for the people living and working in the sector, in the facilities, but for all of us. We really won't be able to contain the virus on a broad community scale without putting out fires in long-term care facilities.
Thank you. And any final words, Dr. Lewis, wanted to add?
No, I would just say that I totally agree with everything Ingrid just said, and would just add that, yeah, if we don't control it in the long-term care facilities, we can't control it in the community at large. But unfortunately, it's the opposite is true as well, or the other side of the coin is true as well. If we don't control it in the community, then we can't control it in the long-term care facilities. So we really have to do a lot of work in both of these areas and safely reopen, in a slow, deliberate way in order to prevent future issues in both of those sectors.
Wonderful. And I wanted to point our media partners to publichealthinsider.com. We've just published a blog that has some additional information and content about some of the work going on in the long-term care facilities. So once again, publichealthinsider.com, published a blog a few minutes ago on that. And with that, this concludes our telebriefing. I want to thank again Ingrid Ulrey and Dr. Lewis for sharing all of your insights and what public health is doing about this, and all our participants today and media for covering this really important issue. So thanks again, and with that, we'll conclude.